Okay, perfect. All right. So if you guys are watching this at home, today is going to be a practice question Kahoot Kahoot day, where we're going to do some practice question and Kahoot and preparing for the exam tomorrow on Wednesdays for you guys. So this is the attendance QR code. Please sign in. I really appreciate that. So I'm going to share my screen for the, let me stop sharing real quick and then, okay. Okay, sorry guys, please give me 1 second. Just give me 1 second, okay? I have one technical issues. Can you guys see the Kahoot screen? Perfect, thank you. So please go ahead and sign in with this pin, and so that we can go ahead and get started. Okay, I'll give it into 4:05 and then we can go ahead and get started. I have 13, 6, 9, 11, 6, 9, 12. Okay, all right, so everybody in? I have 12 people, so I'm gonna go ahead and get started. I have multiple people watching on my screen. Perfect. No problem. All right. Perfect. So let's look at the question together. Nephrotic syndrome has a problem with low albumin, which is correct because in nephrotic syndrome, we pee all of the protein out. The permeability of the protein is so high that it literally don't get filtered. It just literally go through the nephron and we pee all of the albumin out. So 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 this is also means there is an issues with clotting cascade and the patient need IV heparin. So protein is a factor in the clotting issue. Protein is one of the major part in the clotting system. So that's why the patient needs IV heparin as well if there's an issues with the protein. All right, let's go ahead and move on. All right. Oops. Sorry, I should have explained that question. So the question was about the intrarenal injury. So the like I told you guys before, acute tubular necrosis is one of the most common cause for the intrarenal injury. So just please remember that. All right, renal angiogram. So for this question, I will remember that. So for the kidney, if she asks you guys questions about which is the safest diagnostic test for the kidney, it will be the bladder scan or ultrasound, because there's no contrast dye involvement, and that will be the least invasive procedure. But for this question, if it goes into the kidneys and visualize perfusion, it will be renal arteriogram. All right. What is the priority intervention for a patient with glomerulonephritis? So all of these are the correct answer. Before I look at the result, I thought it was restrict fluid, sodium, and proteins as well. But the reason administered diuretic is the most important one, because currently the patient retaining water. In glomerulonephritis, the kidney does not produce the urine or produce very little urine. So we want to administer the diuretic so that the patient can reduce the swellingness and the retaining water in the body. But all of these are correct. We restrict fluid, sodium, and protein. Restrict fluid again because we don't want fluid to retain in the body. We already have too much. And sodium is because sodium attracts water, and proteins is because proteins is a big molecule, and in glomerulonephritis, we don't want to overwork the kidney. So that's why we need to decrease protein in glomerulonephritis. But in nephrotic syndrome, we need to increase the protein in the diet. And steroids, so glomerulonephritis is an infection. It causes inflammation. So steroid will help with decreasing the inflammation. And antibiotic is to treat the infection that causes the glomerulonephritis, the strep. Yes, so glomerulonephritis often causes by strep. So please remember that. Perfect. So we start antibiotic before obtaining culture. This is wrong because if we start antibiotic before obtaining a urine culture or any kind of culture, we will affect the result of the culture. The reason for obtaining a culture is we want to identify the specific bacteria that the patient is having so that we can use the specific appropriate antibiotic to treat that bacteria. So we always start first with obtaining the patient urine culture or any kind of culture. And then we start them on broad spectrum antibiotic while waiting for the result to come back. And when the result come back, we then start the specific antibiotic to treat the patient infection. All right, so in oligoric phase, the phase where the patient don't produce a lot of urine and they retain a lot of waste in the body. So that is the reason why they're most fatigued. Initiating phase is when they start showing signs and symptoms of kidney issues. Diuretic phase is the progress phase where they start producing a little more urine, and recovery phase is when they are becoming back to normal again. So for this, remember oliguric phase, they don't produce enough urine, like less than 30 milliliter per hour. All right, awesome. So yes, in diuretic phase is the phase when the patient start to urinate a lot. So that's why they at risk for dehydration and hyponatremia, because they peeing, excreting a lot of fluid. Um, Perfect. So this question may seem very easy, but it's a good reminder that glomerulonephritis is caused by a strep infection or lupus. But strep infection is often the most common cause for glomerulonephritis. Perfect, awesome. So this question is also important to remember. Abdominal girth is a evaluation tools that we usually as nurses do when the patient having ascites or they just finished the procedure, the paracentesis to remove the fluid, the swelling is inside the belly. So if there's question regarding like what is the most effective tool to measure, to evaluate the effectiveness of paracentesis or anything involved with ascites, abdominal girth is the best tool to measure. Perfect. Awesome. So for this question, please remember the initiating phase will continue until the sign and symptom appear. When the sign and symptom appear, then it will become the oliguric phase. Awesome. So aldosterone is the hormone that aids in the regulation of blood pressure. It causes the retention of the sodium, so that when the sodium is high, we will retain more water, and because we retain more water, we increases the volume. Therefore, we of the blood, and therefore we increases the blood pressure. Erythropoietin is a hormone that produced by the adrenal gland, the kidney, above the kidney, where it stimulate the bone marrow to produce red blood cells. So that's the role of erythropoietin. All right, so we cross out aldosterone at first because we know that aldosterone is relating to the volume of the blood, where it increases sodium and lead to retaining water. Oxytocin is more dealing with OB, I think, where it helps stimulating the to help delivering the baby. Testosterone is more like gonads and like males and like the genitalia stuff. So angiotensin is the hormone also secreted by the kidney. It's involved with the also involved with the blood pressure. So it causes vasoconstriction and lead to increasing the blood pressure. All right, so glomerulonephritis. So what patient below includes fluid volume overload. So we need to restrict sodium, fluid, and dietary protein if BUN is elevated. So the reason why it's not pyelonephritis is the infection of the kidney. And in pyelonephritis, we want to increase the fluid in the patient so that the patient can pee out and the bacteria. So we cross that out because we want to increase the fluid in pyelonephritis. In nephrotic syndrome, we want to increase the protein. So that's why we don't choose nephrotic syndrome. So please remember that we don't restrict protein in nephrotic syndrome, because in nephrotic syndrome, we pee out all of our protein. So we want to increase the diet, the protein in the diet. Whereas in the glomerulonephritis, we need to decrease the protein because we don't want to overwork the kidney. Acute tubercular necrosis, just remember that acute tubercular necrosis is the most common cause for intrarenal injury. All right. Perfect. Awesome, guys. So pre-renal issues of the kidney is anything above the kidney. So anything that causes a decrease in cardiac output that leads to a decrease in perfusion of the kidney is considered pre-renal issues. And hypovolemia is the biggest cause because when we lose this blood, we don't have enough blood to share to the distant organs such as kidneys. So that's why it is one of the biggest cause for pre-renal issues. All right, so cystoscopy is a catheter insert into the bladder to get a visual within the bladder. So yes. Awesome. So like I mentioned earlier, aldosterone, it helps to increases the sodium level in our body, therefore causes a retaining water and therefore lead to an increase in blood pressure. Angiotensin is more about the diameter of the blood vessel. It causes the constriction of the blood vessel. Yes, so this is also important to remember. Hyponatremia can cause seizure, mental status changes, and cerebral edema. And the first sign that often happen is the change in level of consciousness. Patient will get a little confused, and that's when we know that they are having possible issues with cerebral edema, and we need to monitor the sodium. So hyponatremia can cause these. All right, perfect. This is just the explanation from the book. But basically pyelonephritis is infection of the kidney. Perfect. So I think this was one of the things that she mentioned in class before. So that's why we put it in here. So we can, if even though if the patient has severe kidney dysfunction, but we have to give them contrast dye in order to provide a diagnostic test. We can give them mucomis and then recommend them to drink more fluid to help excrete the contrast faster so that it doesn't, it's not as damaged. All right, awesome, Sky. So 10 to 20 is BUN, 135 to 145 is carbon dioxide, 3.5 to 5 is potassium, and 1.5, 0.5 to 1.2 is creatinine. All right, so all of these lab, they show us the function of the kidney, but the key word here is the hydration status of the patient. So it will be the BUN. The higher the BUN, the lower the hydration status of the patient. eGFR is how well the kidney is being perfused, how much how much rate of the volume of the blood is perfused to the kidney. So that's eGFR, and creatinine is the main lab for the renal function, but BUN is the hydration status of the patient. Awesome, guys. So vitamin K is the antidote for warfarin. Another name for warfarin is coumadin. So please remember that. And protamine sulfate is an antidote for Hepburn. So yes, please remember. So eGFR, the rate of how much blood perfusing the kidney. So it also shows us the degree of the kidney damage in chronic kidney disease. These questions are not worded really nicely, but the main thing is just know briefly about each of the lab indicate. We know that creatinine, BUN, and eGFR are the three main lab for the kidney. And again, creatinine is like the lab indicating the function of the kidney. BUN is like the hydration the patient is, and eGFR is the rate of the blood perfusing the kidney. And I guess if the eGFR is low, it means that the kidney is being damaged because there's no blood perfusing. Awesome, guys. So acute tubular necrosis is the #1 most common cause of intrarenal failure. Awesome. Yes, so the normal lab value for BUN is 10 to 20. How I remember this is like BUN is like a burger. So like a burger is like 10 to $20. So that's how I remember it. Awesome. It is the biggest is bleeding is correct because we go inside the bladder. So it's an invasive process. So in my note, I have more than 90, but I'll check this with the professor again, but in my note, I have anything above 90 is good filtration. But the more important thing to remember is if eGFR is less than 15, that means the patient required to have dialysis, less than 15. All right, so oliguric phase is relating to the kidney, so we already can eliminate respiratory issues. So we stuck between metabolic alkalosis and metabolic acidosis. The reason why it is acidosis is because we don't excrete the waste out, and the waste is very acidic, like the urea, the ammonia, those stuff, they are acidic. So that's why we have an issues with metabolic acidosis. Awesome. So please remember, bladder scan is the least invasive procedure and should be done first before any other diagnostic to see if the patient is retaining urine in the bladder. Yes, so anything N in sin or mycin are nephrotic, anti-nephrotic toxic to the kidney. So if there are questions about that, please don't pick the antibiotic that have the sin at the end. All right, daily weigh is the biggest assessment for the function of the kidney. I would have picked INO too. Daily weigh is important, but I think that it is because like if the patient suddenly gain a lot of weight, it can indicate that the patient is swelling. So that's why daily, and we need to report to the doctor. But I would have picked I know. So I'll look up this question and make sure to give you guys a better answer. But I know is what I would have picked, because if the patient have an output of less than 30 milliliter per hour, we need to report that to the doctor. All right. So they cannot get IM injection because patient with nephrotic syndrome, they have an issues with protein and albumin, and their muscles are really weak, and they have issues with synthesizing and absorbing proteins. So that's why we cannot give them IM injection. Awesome. So the key here is the less than 400 ml per day. If the patient produces less than 400 ml per day, it means that the patient is currently in oliguric phase. Awesome. So the priority intervention for patient with renal calculi, renal stone, is pain management. That's the priority. All right, awesome. So nephrotic syndrome is increased permeability to the plasma protein. The reason why it is confusing glomeruli right here is because the anatomy of the kidney, this is the kidney, and in the kidney they have million of the nephron, and the nephron contain the glomeruli. In glomerulonephritis, the glomeruli is inflamed, but in the nephrotic syndrome, the glomeruli was inflaming so much that it just give up, and it's just having a lot of holes inside the glomeruli, and causes an increasing permeability to the protein, where the protein just goes directly through the glomeruli without being filtered, and we pee all of it out. So it is nephrotic syndrome. Anything increase the permeability of the protein will be relating to nephrotic syndrome. All right, so creatinine is the #1 indicator of kidney failure. So anything, the higher the creatinine, the worse the function of the kidney is. And the creatinine is, normal range is 0.5 to 1.2. All right, awesome. So again, BUN indicate the hydration of the status of a patient. So the high BUN means the patient is dehydrated. Perfect, awesome, guys. So all of these are the post-renal complication for the patient. Post-renal because UTI is occur below the kidney, and kidney stone is also occur below the kidney. Awesome, perfect. All right, so we finished the GU. I'm gonna go ahead and stop sharing, and then I'm gonna pull up the respiration so that we can do the respiration real quick. Do you guys have any questions currently? This is the respiration Kahoot. So let's join me in this respiration Kahoot. It's a different pin. Perfect. I think I have everyone, so I'm gonna start. All right, the correct answer is C. So let's look at the questions again. So which patient has highest hypoxemic respiratory failure? So when we read the question, hypoxemic, we think internally. And if it's hypercapnic, we think it's kind of like unable to breathe. So a patient who has respiratory muscle paralysis. So if a patient have a respiratory muscle paralysis, they won't be able to expand their lung and inhale air or exhale the air. So they would trap and retain carbon dioxide. So that would be something for hypercapnic respiratory failure. B, a patient who has a fractured ribs and flailed chest. So if a patient have a flailed chest, they have an injury to their one of their lungs or a pneumothorax, and the lungs is collapsed. So the patient still won't be able to exchange the air, won't be able to breathe or exhale the air out. So they will have an increase in carbon dioxide as well. And D, a patient who has slow breathing from a drug overdose. So if a patient is overdosed, they usually the breathing center from the brain is just shut off, so the patient don't exhale or inhale. So these A, B, C, D, they are similar in common. They are similar and similar to each other. So that's why we can cross them out. And C, a patient who has massive pulmonary embolism. So a patient with pulmonary embolism is suddenly the lung doesn't get perfusion. So it will be a hypoxemic, it will be relating to oxygen because the lung doesn't get perfused. You guys know what I mean? It's more internally. I hope that makes sense. All right, let me move on. All right, so PO2, they only give us PO2 issues. So PO2 is oxygen, so obviously it's hypoxemic, right? So anything less than 60 on an FiO2, more than 50%, it indicate that the patient is currently in respiratory failure, or PO2 less than 40, and SL2 less than 90 indicate the patient is in respiratory failure. Perfect. So this is just theory, so we just have to remember this. So VQ scan, is the diagnostic test where they uses radiation isotopes, so we can see how the perfusion is going through the lung. Awesome. So suction control chamber should be continuously bubbling. If there's no bubbling, we need to check from the device to the wall if anything has unplugged or yeah. So just remember this, device to the wall. Perfect. Carbon dioxide, hypercapnic. Awesome. So morphine is a big drug in the respiration chapter in Med-Surg 2. So morphine is being used oftenly to decrease the breathing effort and anxiety of the patient, so that the patient won't get hyperventilating. And whenever they slow down, less anxiety and breathing normally instead of hyperventilating, the workload of the heart decreases as well. So morphine. Awesome. So the hallmark for pulmonary embolism is sudden, sharp chest pain and shortness of breath. So if there's a question, sudden, sharp chest pain, pulmonary embolism. So when we put a trach inside the patient, we need to assess a bilateral breath sound first to see if there are any gas exchange or air movement in the chest, in the lungs area, before we do the endotracheal tube. Endotracheal tube is like when the patient is being intubated. So yeah, I have no idea what this question is about. But yeah, whenever there's a pump failure or ventilator failure, it's going to be hypercapnic, I guess. I don't think she'll ask you something like this. All right, so whenever the patient is being intubated and they show sign of decreased SpO2, which is the post-ox, or they have visible secretion that we can see, or they are being aspirated, we can and go ahead and do suctioning for them. All right, awesome. So agitation or confusion, anything lower level of consciousness related is always the first sign that indicated the patient is have developing rapid decomposition. So level of consciousness related confusion, agitation is what we should pick for the first early sign when the patient having respiratory issues. Awesome. So only BiPAP and CPAP here in this answer, force air into the lungs. Hypercapnic. So we have an acute increase in carbon dioxide more than 50. The regular number is 35 to 45. That's the normal range. So when we have an increase in carbon dioxide, the pH will get acidosis, so it will be less than 730. Normal range for pH is 7.35 to 7.45. Awesome, guys. So if there's a question about the patient have 120 ml or something like that from the chest tube, what is the first thing that the nurse need to do? We need to call the doctor. Awesome. So ARDS. In ARDS, remember the two things that I was talking about before, RAD and BED. RAD is the early sign, restlessness, anxiety, anxious, tachycardia, tachypnea are RAD. Those are early sign. So BED are the late sign, bradycardia, E is extreme restlessness, and D is dyspnea. So dyspnea is a late sign of ARDS. Perfect. So the failure of lung and heart to provide adequate oxygen to meet metabolic needs. So we don't have enough oxygen circulate into the inside the body. It is issues with hypoxemic. Hypercapnic is retaining carbon dioxide. All right. I don't think you guys have to know this, but it's good to know. The mean pulmonary artery pressure is 12 to 16. I don't even know that. All right. So after the patient is mechanically ventilated, we assess the respiratory every 1 hour. All right, so it's just good to remember these. All right, so pulmonary hypertension does not cause by infection, so that's why we don't give them antibiotic. Awesome. So remember the MPAP level is normal range is 12 to 16. So if it's 25, it can indicate that the patient is currently having pulmonary hypertension. The pressure is so high, causes a lot of restriction. All right, so heart failure is the most common cause of pulmonary edema. The heart failed to pump effectively, it causes backup into the lung, lead to pulmonary edema. All of these can cause pulmonary edema. Awesome. Please don't forget to know that never give heparin with any other medication. It goes on itself, by itself. No picky light, no nothing, just by itself. All right, so thrombolytic or TPA. You guys remember TPA? So TPA often used for stroke and MI. We don't use TPA for pulmonary emboli. What do we use for pulmonary emboli? Heparin and warfarin. We start a patient with a loading dose of heparin, and then we also at the same time give the patient Coumadin, which is the warfarin orally, and we check the warfarin lab every day until it reached the therapeutic range. Then we can remove the heparin and continue giving the patient the warfarin medication. Awesome, guys. So FiO2 is the percentage of the oxygen in the environment. So in the room air, normal air that we breathe, the percentage of oxygen is 21%. Awesome, guys. So we want to see constant bubbling in the suction control chamber. We don't want to see bubbling in the water shield chamber, because in the water shield chamber, if there's bubble, it indicates that there has been a leak. So if there is no bubbling in suction chamber, we check from the device to the wall. If there is suction bubbling in the water shield, the chamber, we check for the king. We check for from the chest tube to the patient. Okay, chest tube to patient for water shield. Awesome. So all of these are assessment that we can find in a patient who have pulmonary edema. Secretion color pink and frothy. This is because the alveoli is so full of fluid that it bursts, and then it causes bleeding, so that the patient excreting blood and frothy sputum. So it will be gas exchange only. I think this is a wrong question. I would say both, perfusion as well, because it relating to oxygenation and providing oxygen to the body. So ARF would be both, gas exchange and perfusion. Sorry about that. Perfect. Awesome. So if it's type 1, usually it is the hypoxemic one. All right, so if chest tube dislodged from the device in the image, we will place the end of tube in sterile water, correct? Why this is done before we go and talk to the doctor. So if there are questions about talk to the doctor and put in sterile water, we would put it in the sterile water first. Awesome, guys. Perfect. So anxiety, level of consciousness, anything relating to level of consciousness is an indication of respiratory pulmonary issues. Awesome. So just remember, every 2 hours, we do oral care for ventilated patient. Every 1 hour, we check the respiration, assess their respiratory. Okay. So 2 hours for mouth, every 1 hour for the lungs. Awesome, guys. So we tape only 3 sides of the petroleum gauze and we leave the bottom sides. So this is the square and we leave the bottom one. We tape the 2 sides and the top. All right. So the question was really long, so let's look at it again together. A patient ABG result includes pH 7.31. Okay, pH 7.31, the patient is currently in acidosis, right? PaCO2 50. All right, so they have elevated carbon dioxide. So this may be respiratory acidosis. PaO2 is 51 and SO3 24. Oxygen is administered at 2 liters per minute and the patient is placed in high flower position. An hour later, ABGs are repeated with the result of pH 7.36, PaCO2 40, and PaO2 60, and SO3 24. What is the most important thing for the nurse to do? Okay, so as we can see, the patient has improved, but the PaO2 is still very in the low range. What number is good for PaO2? We want anything above 90 is for PaO2. So that's why we need to increase oxygen flow rate to 4 liters per minute. Even though the patient is improving, but it's still very low, the PaO2 level. That's why A is the correct answer. I think in class it says anything above 60, right? Can someone confirm with me? From what I remember, anything above 90 is the good range, but if it above 60, the patient should be fine. Okay, I'm going to go ahead and next. All right, we need to give them oxygen first, oxygen fast. ABGs, ABC. All right, so the question is wrong. I'm sorry about that. So hypoxia is the problem with too little oxygen, and hypercapnia is the problem with too much carbon dioxide. So it would be too little here. Shouldn't be too much. Sorry, the question was wrong. All right, so I know that we put in 20 milliliter, but it depends on the patient. So we have to do based on a doctor order, but normally it is 20. Perfect, guys. Okay, just remember that it's okay. Sorry about that. Awesome, guys. So pulmonary hypertension, very high constriction, vasoconstriction increases the pressure in the lungs. All right, awesome. So I have one more Kahoot. It's just like about 15 questions. It's not 40 like these, and it's about the cirrhosis and liver stuff. So let's take a 5-minute break, and then we come back, and then we're gonna go ahead and do that Kahoot. Okay, it's very short. Let's take 5-minute break, and we come back at 5:17. Thank you, guys. Everyone, so this is the Kahoot for the liver. It's only about 14 questions. So let's join me, do this, and then we can finish the practice question for today. I hope it was helpful for all of you. I can't do this. Oh, I love that. Me too. I can't either. Okay, so all right. Have everyone? Okay, I'm go ahead and start. So if we have a decrease in albumin, we will also have a decrease in calcium. Okay. But when we have a decrease in calcium, we will have an increase in phosphorus. Okay, I hope that makes sense. All right, so flu-like symptom is a common side effect of interferon A and B. We do not hold the drug if the patient shows sign of flu-like symptom because it's just a common side effect. All right, it is the hepatitis D, guys. Right, so interferon B has a higher risk for suicidal agitation, and both A and B have increased. Both A and B have the risk of suicidal agitation, but B has a higher risk for it. And when the patient are being given interferon, when they show sign and symptom of suicidal agitation, that is the only reason why we will stop the drug. Perfect. A and E, the vowel. Perfect. Cirrhosis is the end state of liver disease where the liver is replaced by fibrosis cells of the liver, where it's just like scarring on the liver. And hepatitis is acute. Perfect. BCD is the type of hepatitis infection where it comes from the body fluids. I mean, yeah. Inflammation of the liver is hepatitis and it is acute. Okay, so be hepatitis C. So we only have vaccine for hepatitis A and B. All right, so liver biopsy is the #1 confirms diagnostic study for cirrhosis. So liver biopsy is the diagnostic study where they confirm, emphasize and confirm that the patient is having cirrhosis. Liver biopsy. Perfect. We only have vaccine for A and B, guys. But we can treat other hepatitis with interferon. Perfect. So only B that has a vaccine and come from bodily fluid. Perfect, guys. Icteric. Okay, last questions. Perfect, guys. So thank you so much, everyone, for coming today. I hope you do the exam very well tomorrow. Is there any question that you guys would like to ask me before I end the session today? If not, I hope everyone had a good time. And yes, remember lactulose. Lactulose, the medication that we give for the patient to treat encephalopathy. I remember there were questions about that, lactulose. Yeah. The laxative where they help to help the patient excrete the stool that binds with the ammonia, and patient can have up to 15 diarrhea a day. Okay. Thank you. Thank you so much for coming. I hope you guys had a good time and good luck tomorrow. Have a good sleep and good luck. Thank you. Thank you. Thank you.